In March of 2017, 30 teams gathered for the first learning session of the Institute for Healthcare Improvement's Conversation Ready Massachusetts Collaborative. The teams came from all corners of the state and represented many different aspects of healthcare: acute care, nursing facilities, home care, hospice, assisted living, and advocacy organizations. The focus of the two-day event was to increase patient engagement with their healthcare proxies, understand what matters most to those patients, and then shepherd this information to medical records until the day comes when patients need it. What is an IHI collaborative? What is the experience like for participants? And why did we choose this model of education for this conversation-ready work? The traditional IHI Breakthrough Series collaborative model includes well-tested content, 3 in-person learning sessions, active action periods with monthly phone calls and reporting, and a common aim. This particular collaborative, which was funded by the Gordon and Betty Moore Foundation, emerged from work that began at IHI in 2012. That fall, 10 pioneer sponsors helped design the work and discover the key changes needed for improvement. The work evolved tremendously in the nearly 5 years between then and the launch of the one-year collaborative, which now included a change package and a measurement strategy that the teams are using to drive their work. This first learning session, a 2-day event, included more than 100 people on 30 teams and faculty and staff from IHI. An active meeting agenda focused on building will, sharing ideas, and teaching an execution model, the model for improvement, so that participants would walk away ready to test changes. At the start of the meeting, for 30 minutes, teams had an opportunity to meet the faculty and staff team from IHI and learn about the collaborative model, including the history and aims of the work. Then we called forward 5 pre-selected teams to share stories that we gleaned from their pre-work exercise. In this case, it was to review charts from the last 20 patients who died. These stories highlighted areas of excellence in their systems, as well as areas that needed improvement. After that, we shared the framework for the conversation-ready work, highlighting the 5 principles: engage, steward, respect, exemplify, and connect. These principles provided the high-level view of the work at hand, along with the organizational structure for the change package and measurement strategy. Once teams learned about the principles, the faculty, 2 physicians from Massachusetts and Rhode Island, who served on pioneer sponsor teams at the start of the conversation-ready work in 2012, shared the change package with teams and gave participants vivid examples of how the prior organizations involved in the work made the changes in their settings. We then asked teams to start thinking about which changes might be good starting points for their organizations. After lunch, the teams had 1 hour to engage in storyboard rounds. All 30 teams had prepared a storyboard using a PowerPoint template to share information about their organizations, their prior improvement efforts, and the learning from the pre-work exercise. They engaged energetically and told us later they wished they'd had even more time to talk with one another. Storyboards, we've learned, are a key component of each learning session. After the storyboard rounds, teams learned about the measurement strategy and the model for improvement. IHI improvement advisors taught both of these sessions, which are always well received. At the end of day 1, participants met with their own teams for 1 hour to continue writing their aim statements. On day 2, after answering any lingering questions and clarifying any issues that participants noted on their day 1 evaluations, we convened a patient and family panel for over an hour, comprising members of the Beth Israel Deaconess Medical Center Patient and Family Advisory Council. These panelists shared some of their history related to engagement around end-of-life issues and then answered a wide variety of questions from participants. After the panel, teams went to breakout sessions for a deeper dive into the changes and the measures. Then we presented a second Model for Improvement educational session with a focus on learning about PDSA cycles. After lunch, participants again met with their teams to make plans for their first PDSA cycle and to complete a project planning form for the first action period that would lead into Learning Session 2 in July. Before day 2 ended, teams shared their plans for their first PDSA and a headline of something that they believed would be true about their organization in 1 year. We closed by asking teams to post their first test results on the listserv and come prepared to discuss their first PDSAs on the first all-collaborative call the following month. From start to finish, it was an engaging and energetic learning session that left participants, faculty, and staff excited about the learning ahead.